For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Season 4, Episode 40 of the podcast, still known for now as Surfing the NASH Tsunami. Our review of last week's Paris NASH meeting starts now.
This week on Surfing the NASH Tsunami.
I have to say that so far I haven't seen the tsunami. I'm still waiting for the waves. Maybe next year, with a new treatment coming, will be a different situation.
There are huge gaps in our knowledge in NASH and in all diseases to explain why the injured liver doesn't regenerate as well. And of course, the implication is if we uncover those signals, we have new therapeutic targets that may enhance regeneration.
There are ways to balance statistically the safety profile of a drug and the efficacy.
I wonder whether or not we don't utilize CAT as much as we should, particularly now that we have it.
There is a behavioral component to this, right? As we get drugs, we're going to need to keep patients on them.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guests, hepatology researchers, and key opinion leaders Scott Friedman and Laurent Castera, as they review highlights from the Paris NASH 2023 meeting on Surfing the NASH Tsunami.
So I'm guessing most of you noticed we didn't record last week. We had planned to do a preview of Paris NASH. I had planned to be at Paris NASH. And then we had an unfortunate, untimely death in my family, and I wound up having to spend the week in the States. So we were not able to produce an episode with me completely out of commission on short notice. We are back happily this week, though. We have Jörn with us. Hey, Jörn, how are you doing today?
Good evening, Roger. Sorry to hear about your loss, and happy to have you back on here.
Thank you. Second time in the last 5 months I've lost a cousin young. This has not been my favorite year. Well, not go in the books as my favorite year. Louise is with us at 1:30 in the morning in Perth. Louise, how are you doing?
Yes, I'll say good morning to everybody. I'm on a totally different day.
Yeah, it's true.
But it's nice to have everybody on board, and obviously deeper sympathies.
Thanks. And then we have two of our very favorite guests with us. On my left is Laurent Castera. Laurent, thanks for joining us this evening. How are you today?
Fine, thank you. Hi, everybody.
Glad you're. And then Scott Friedman, who is resplendent in a pink polo shirt that you might never see, depending upon whether I put up photos of this or not. Scott, welcome back to the States. How are you doing today?
Glad to be back. Glad to have attended the meeting. Good to see you, Roger, and my condolences.
Thank you. So with that, Scott has a hard stop in about 52 minutes, so why don't we just dive in? Usual icebreaker. One good thing that's happened in the past week, personally or professionally. Please try not to make it about Paris NASH, since that's going to be the rest of the conversation. Brave one, go first.
Let me start. Germany actually won the World Championship in basketball, I believe, and I didn't even know where the best player had his position, so you educated me, Roger. It was the guard player, Dennis Schroeder, who did a good job, I think, during the tournament. I watched the game last night evening. It wasn't quite as high scoring against the US, but it was fun to watch, and there's a lot of emotions on their side, obviously.
Winning is always fun, and yeah, there were a lot of emotions on their side, weren't they? They're not the easiest guys to play against when they're losing. Fair enough. Congratulations on that. Next.
I'll just say that while I won't mention Paris NASH, I will mention France, because I preceded the meeting with 3 days in the south of France, which is as magical as you might think it is. The weather was perfect. The scenery was spectacular. The history was great. Museums, food, you name it. All that France has to offer and more.
Congratulations. That's fantastic. Louise or Laurent, either one of you go ahead.
I'll jump in next. I wasn't at Paris NASH because I was speaking at the Australasian Hepatology Associated meeting, which is a meeting set up by nurses and a group set up by nurses 21 years ago. So they were celebrating their 21st anniversary, which is a great milestone, and sharing some great practice and models of certainly viral hepatitis care in the communities, but also how far they go and how they get people engaged with FibroScan. And we have to remember that here FibroScan is not reimbursed. So it's basically only coming out of liver areas or anywhere that manages to absorb the cost themselves. So it was a great meeting. It was very wet and cold in Melbourne, I had to buy boots to even go there because I only have summer shoes for Perth, far warmer city.
And then, Laurent, your good news of the week.
Yes, so last week, contrary to Australia, it was very hot in Paris, and Paris was hosting not only the Paris NASH meeting, but also the Rugby World Cup. And you know that on Friday night, France won the game against the All Black of New Zealand. So French people are, of course, very proud and happy about that.
Must be a huge upset. New Zealand are the perennial powerhouse.
Yeah, congratulations on that, Laurent. That's very exciting.
I was wondering what all the screaming was about in the streets on Friday night. Now I know.
I'm going to the final, and I hope to see France there, to be fair, as well as England.
So, Louise, would you like to share what your husband's doing this week?
Well, my husband this month is following England round France, and having been in Marseille and driven down there after flying back to the UK last week. He doesn't get back to the UK till the 27th, and then we're both in Paris for the finals. So a little bit of a treat. So he will be driving a lot of France in that hot weather, Lauren, but enjoying everything the French have to offer.
So I guess my good news, in a manner of speaking, is that last week really was about the circle of life, and that I got to meet a couple of my young cousins, ages 3 and 6, who I'd never really gotten to spend any time with before. And they were delightful as little children were, and they were a reminder at that moment that as people are departing, people are joining us. Kids are fantastic, you know, and as Jörn knows, because Jörn's kids aren't so different in age from the ages that I just provided. Not to put too fine a point on it, but that was a good moment in a tough week. So with that, let's dive into our conversation. Paris NASH is a pretty dense conference. Instead of going through the whole thing section by section by section, I'd like to take a slightly different approach. First of all, each of our 3 KOL guests, well, Jörn's not a guest, Jörn and our 2 KOL guests each presented at the meeting. So what I'm hoping each of you can do first is take a couple of minutes and talk about the work that you presented there and share that with our audience. And then we'll go back and share a couple of other things about the meeting. Brave one, go first.
I'll jump in. One of the things about Paris NASH that is very exciting is that Arun and Laurence, who are the 2 organizers, always pick really cutting-edge topics and also some provocative topics and questions that engage people who think about the disease a lot. So this is not a meeting for amateurs, so to speak, because the topics are very nuanced and difficult to answer. For me, that's very exciting. Now, they asked me to speak about something that I'm also very interested in, which is the link, if any, between fibrosis and regeneration. And so I had the pleasure of sharing a lunchtime session with Fabio Marra. For my part, I really tried to emphasize how little we know about the link between why fibrotic livers don't regenerate well and why regenerative livers don't develop fibrosis as they regenerate. We don't know what the signals are, and it's worth reminding ourselves that no other organ except liver has this remarkable capacity to regenerate and regenerate over and over again through repetitive liver injuries over a matter of decades. You know, I also pointed out somewhat cynically that I've been in the business for almost 40 years, and every 10 years there's another fashion of what drives liver regeneration. It started with epidermal growth factor, EGF, HGF, and then it was insulin and glucagon, then it was stem cells, then it was epigenetics. I'm not sure what it is now, except maybe single cell technologies revealing subsets of cells that are particularly regenerative. The point being that we have a lot to learn. And we had a very stimulating conversation, which made us all realize that there are huge gaps in our knowledge in NASH and in all diseases to explain why the injured liver doesn't regenerate as well. And of course, the implication is if we uncover those signals, we have new therapeutic targets that may enhance regeneration. And if we enhance regeneration, that may ignite an endogenous program to cut down or degrade scar. Conversely, if we develop therapies that degrade scar, we may ignite an endogenous regenerative program. So there's lots of prospects for progress based on new technologies, but lots of gaps in our knowledge that need to be addressed in the coming years.
Scott, if you had a hunch, which one of those 2 prospects that you just raised would you consider more likely?
I actually think that if there is a program that comes from a regenerating liver or liver cell or subsets of liver cells that tells the liver, break down scar, we don't need you anymore. Well, the reason I say that is, or I leapt to that answer, Roger, is because we know in the natural experiment of treating underlying viral hepatitis, which are drugs, whether hepatitis B or C, that solely clear or suppress virus in hepatocytes. They have no antifibrotic activity. Yet when they exert their activity in suppressing the virus, fibrosis melts away. So there must be signals coming either directly or indirectly from hepatocytes that have been cleared of the virus that are saying it's now time to regress scar and restore the normal architecture, which may be a default once you get rid of the injury to hepatocytes.
And unfortunately, I missed that lunch session, Scott. I would have loved to join, but I missed parts of the first day. And I guess you mentioned the Hep C example, which is great. My question would have been, how much is disease specific and how much is just, the pure preserved mechanisms of scarring the liver, which is probably throughout all different insults very maintained. Do you think the underlying etiology matters to a big degree, or what's the data saying here?
It's certainly across etiologies that cause chronic liver disease. My first answer is the etiologies are not so critical because the liver has a major way of repairing and restoring regeneration. Having said that, I've also come to recognize that the devil is in the details, and that recognition comes from the use of single-cell technologies that have defined subsets of different cell types that subserve different functions. And they may be that the response to injury and the clearance and the regeneration that follows may be subtly different between hepatitis B, hepatitis C, alcohol, NASH, or other diseases. I would conclude by saying I think these processes are much more similar than different across etiologies, but there may be subtle differences that we'll learn about as we uncover some of the answers to these questions. Also, if you were alluding to the prospect of regeneration in other tissues, I think that's an even more vexing question because it comes back to the issue of why only liver? What is there that's unique about liver that you can surgically remove 2/3 of a healthy liver and the liver will grow back? And that certainly won't happen in lung or kidney or any other organ. So even if there are shared mechanisms across different liver diseases, they're less likely to be shared across other tissues that get scarring.
Fantastic question, fantastic answer. So Laurent or Jörn, whoever wants to dive in and let our audience know a little bit about what you were speaking about at the meeting.
I had the pleasure to chair again also a lunch session with Dr. Mark Mutia from Singapore on the pitfall and limitation of the use of NIT in NASH patients. And I have to say this was a very interactive session, and we started from a simple clinical case, and we went all the way to show and to share with the audience how we could use these NITs in the different aspects of the diagnosis and the follow-up of the disease. So first, of course, you can use a simple test like FIB4 to enrich your population and to spot among patients with risk factors those who are likely to have advanced fibrosis, and that should be referred to an expert center because, as you know, most of these patients are seen either in primary care or for some of them in the diabetes clinic. One of the hurdles to implement, because the good news is now we have 4 international recommendations on sequential algorithm using FIB4 as first test, and then a more specific test like ELF or liver stiffness using VCTE. And these recommendations are aligned, which is a good sign, and not only association like, of course, EASL, ASLD, AGA, but also the endocrinologists with the QZ recommendation. And I think this is a strong signal to the field and the way to go. But one of the barriers to the implementation of this algorithm is a lack of awareness of many colleagues, especially GP. They're also overwhelmed by the burden of patients. Even though they see some of these patients with metabolic risk factor every day, usually they deal with hypertension, with diabetes, with obesity, but they tend to scotomize kind of the liver. And we clearly need to work on raising the awareness of the liver and showing that very simple tests like FIB4 that can be implemented tomorrow in your clinic can be used. And the major advantage of FIB4, not only it's very easy to calculate at the bedside or in the outpatient clinic, but also it's very cheap and has high negative predictive value. One of the only drawback actually is to adapt the cutoff according to the age if you're targeting population that are above 65. So instead of using the 1.3 cutoff that is currently recommended, you should probably use a higher cutoff like 2, for instance. Otherwise, for instance, in France, we started to implement with the labs automatic calculation of the FIB4 by the labs when they're seeing patients. And this could be a way to leverage the awareness and the use of this algorithm. So maybe I don't want to be the only one to discuss and talk, and I would value, of course, the other comments, Jörn, Louise, or Scott.
Yeah, thank you, Laurent. Nicely revisited. And again, there were a couple of workshops in parallel, so I didn't get to join yours here for the lunch sessions. But from what you're telling me, it is the revisiting of the challenges we're facing in the field, where we have a first test that's easily available, has some pitfalls, but is readily implementable in many settings. And you mentioned the automated implementation in labs that will be very helpful for non-hepatologists to risk stratify and refer. And I agree, and I'm aligned with you on the value as it's been shown in many guidelines. So I think that's an important message here again. And I'm not sure how the discussion went in the room, but I think albeit all shortcomings, in particular, if you do a FIB4 repeatedly, I think you'll be in the end able to identify the patients that will need referral and further workup.
Can I ask, Laurent, because your work's legendary in this, let alone all of the advancements now in litmus and things, whether or not we looked or considered beyond liver-related mortality? We look at liver-related mortality as hepatology experts, and it's a small amount of all-cause mortality. Should we be looking further downfield? Not necessarily all population screening, but there's a very good session that Phil Newsom did a few years back that pulled up some slides for the UK, Germany and France on figures that were based on Yubir's work. And within that, when we only looked at liver mortality, we were looking at a population of just over 500,000 people. But when we were looking for the ones that we don't look for, we don't see them as a cost for liver. That was 28.8 million people and a cost of 45 billion against those with liver-related issues, which was 7.7 billion for anybody over the F2 category. But if you translated that with US costs that were done at a very similar time and the same populations, when we talk about F2 and above, we're talking about a population in the UK of just over 500,000 people. However, and the cost of that was about 7.7 billion a year. Whereas we are not looking for the 28.8 million people who cost healthcare 45.7 billion, who are developing cardiovascular disease, heart disease, and poor liver-related health. We're waiting for them to get further down the line, and we don't consider it effective. So it was a case of how broad do the NITs need to be to go beyond just liver fibrosis, and we need a little bit more of MASH and MASLs, really, and this cardiometabolic effect.
You're right. I mean, so far the NIT are effective, especially for spotting advanced fibrosis. So that is F3, F4. As for NASH, there's been many attempts, including on the imaging side and on the circulating biomarker side, and none of them are really satisfactory. So more recently, there have been attempts of combining or providing composite score, such as the FAST score. That was the first one, but now there's the MAS, the MEFIB, MASEF, so many score. And the endpoint there is at-risk NASH. So basically, the inclusion criterion for current trial with a NAS score above 4 with one item of each, and F2, F3 fibrosis. So to me, the issue is they are not all as well validated. Basically, the most validated is the FAST. We have a very recent meta-analysis that has just been published in Gut with around 5,000 patients, and basically confirming what has been shown in the initial paper in the Lancet Gastro. And you always end up with around 30% of indeterminate results. With the dual cutoff strategy, the NPV is better as usual than the positive predictive value, the PPV, because the PPV is between 60 and 70%, so not completely satisfactory, but still, I think in the context of trial, it allows to hopefully decrease, the screen failure rate. But this is in a different setting, and again, once using NIT, context of use is critical, and people tend to forget the context of use. I want also to stress that most of the studies we have on NITs come from tertiary referral centers, where the pretest probability, that is the prevalence, let's say, of advanced fibrosis, for instance, or NASH, is much higher than in the general population. So usually between 20 and 30%. Whereas if you're targeting the general population, including at-risk patients, it's no more than 5%, between 1 and 5%. And this has a very important influence difference on the performance. Even if you're using a test with, let's say, 80% sensitivity and 80% specificity, given the prevalence going from 5 to 20%, you end up with a high NPV, let's take FIB4, for instance, that can be close to 98%, but the PPV is less than 20%. And if you're using the same test in a different context of use, that is, for instance, a liver clinic, then you reach maybe 50% or 60%, but still you have 40% of patients that may be false positive. So coming back to my initial point, these tests like FIB4 are very effective to rule out, let's say, the 70% of patients at risk who do not need to be assessed in a liver clinic. And another advantage, not only FIB4 is cheap and widely available, but you can repeat, let's say, every year or every 2 years or every 3 years. This we can discuss. And of course, if it gets elevated, then you can start from restart and refer your patients to for further evaluation. Then, of course, you need to deal with the poor predictive positive value and the concern about an over-referral to the liver clinic. I have to say that so far, I haven't seen the tsunami. I'm still waiting for the wave. Maybe next year, with a new treatment coming, will be a different situation. But so far, I haven't seen the wave. Again, happy to share this thought with you. And this time, I hope my connection is okay.
And we're delighted to be surfing with you here, obviously. This discussion leads over very nicely into the topic I was given by the organizers. And I don't want to hijack your talk, Laurent, but the challenge, and Laurent Serfati asked me straightforward after the question is, once you get a treatment in the clinic, which test are you going to use to decide if the patient gets the drug? And I said, I'm not going to use liver biopsy, but then I had to say what I'm going to do. And that step was much more difficult, also based on what Laurent said, because the positive predictive value, I can't use FIB4 because then 60% of the patients are not the ones I want to treat. So you mentioned FAST, which was designed to do that, but still the positive predictive value wasn't quite where we wanted. So we need a little bit more sophisticated. The title was using NITs for treatment decision. And I recapitulated. I'm happy to give some of the content back again. So the task will even be more difficult to determine which patient to be treated for how long and how to determine treatment response compared to identification of patients. And I'll be happy to hear your thoughts on that, Laurent, or maybe also Scott, based on some novel technologies and markers we might be seeing in the future.
Well, I don't have more wisdom than either you or Laurent on this issue, but I have a parallel question, which is once you commit a patient to therapy, how are you going to know whether they're in this case of Madrigal's drug, the 25% who are responding or the 75% who aren't and therefore need to stop therapy and consider something else? And I haven't heard many discussions at all about that. So I'd appreciate the experts' thoughts about what are you actually going to do to know if your patient is responding? Well, you're going to wait for the ALT to go down or MRE or just a FibroScan. How are we going to know when it's time to stop the drug if it's not working?
A tough question. And I think at the end, we're going to use markers that are available. So when I prepared for the talk, I realized that a lot of the data we were given are accumulates and not so much individual patient data. So I didn't see a lot of spaghetti plots showing these patients are not responding, getting worse, where a lot of times we're seeing like the median results. And that doesn't help us at all to make those decisions, Scott. And I'm on your side here. So we need, if a sponsor is listening, please give us that data. Also, we want to see more data being combined to actually say what does the dynamic of the biomarker mean also in the placebo arm if they responded. So to draw strong data from that. But again, I'll pass it over to you, Laurent, and then I'll maybe share my favorite biomarkers for that. But I'm not sure where we want to be yet.
Yes, no, I think we're really on the same line. There's several issues. The first issue is that we don't have much data, and you need, of course, data with placebo arm and paired liver biopsy. And we have this data in the regenerate trial. And basically what you see, of course, people on placebo do not have much change. So I'm talking about liver stiffness, but there are other markers that have been tested. And people that are taking treatment have a decline over time. And there seems to be a correlation, or let's say a trend toward a correlation between what you see about liver stiffness kinetics over time and histological response to treatment. But I completely agree with you, Jörn. These are trends, aggregates. At the individual level, it's impossible to predict in which group you are. Another issue, I think, especially with liver stiffness, is the variability over time. And actually, I I delved into the literature to look more into detail. And to my surprise, there's only 2 papers that dealt with this issue. So a paper that was published almost 10 years ago by Thierry Poinard, taking patients, so it's a retrospective monocentric cohort. So these are, of course, drawbacks, with around 500 examination, let's say between 1 day and 1 year. So a median interval around 8 months. And to make a long story short, this, I have to say also, only a minority of these patients that NAFLD, around 15%. Most of them were with viral hepatitis. And there was quite a wide variability depending on the relative variability. So that was the liver stiffness delta between first and second exam, 20, 30, 50%. And 20%, you had around half of patients with 20% over the whole spectrum of liver stiffness measurement. And of course, you have to take into account, given the wide spectrum of value, if you have a 20%, let's say, decrease or increase, it depends where you stand. And if you have 8 kilopascal and you go above 10, I think it's completely different than if you have, let's say, 45 and you go to 50 or 55. So this also has to be taken into account and put in perspective. So when you look at this data, there is basically high variability. And we don't have clear data in placebo group with paired liver biopsy analyzing this variability. And just, I don't want to spend too much time on this study, but this is the only one we have. Basically, you see that the factors associated with this variability, no surprise, are BMI, operator experience, of course. If you have the same operator between the first and the second exam and a senior operator, you decrease the variability. Also, of course, BMI, this we know, and probably also inflammation. So what is difficult with liver stiffness is really to discriminate the role of inflammation and fibrosis. And this has been nicely shown, for instance, in hepatitis B, because this is the only setting where you have large studies with paired liver biopsy. And usually what you see when you treat your HBV patient with NUCs, there is a two-phase decline. So basically, within 6 months, you have a sharp decline that is parallel to the ALT decline, and this is likely related to inflammation. Then you have a second, less steep decline, much slower decline over time. And this is once transaminases are normal, and this is more likely, we're not completely sure, related to fibrosis. And of course, I would be interested, Scott, to have your opinion about that. But again, the amount of data in the literature is not that high. And even though we have this study by Patrick Marcelin showing with tenofovir that over 5 years, you have a regression of fibrosis in most patients, including cirrhosis. So these are strong data. But still, how can we use liver stiffness to monitor this so-called regression of fibrosis? We need clearly more data and more evidence.
Well, I mean, the reassuring part of the answer to your question, Laurent, is that whether a reduction in stiffness reflects reduced inflammation or reduced fibrosis, they both correlate with improved outcomes. So while in principle we'd like to know whether it's just the inflammation or is it the fibrosis that's getting better, either one will suffice as long as the stiffness values are consistently decreasing. Both correlate with improvement. The only other consideration is whether newer technologies that are really fibrosis specific, I'm talking about here imaging tests that may measure the amount of collagen that are being developed, or perhaps even things like ProC3, which is a fibrosis specific reagent, may add more ability to discriminate between inflammation and fibrosis.
Here's what Laurent has said importantly. I think it's depending on the dynamic of the change. If you achieve it early, it might mean something very different compared to the middle and late stage improvement. I think that needs to be emphasized. So the answer of my talk also was it's not a single NIT and you have to interpret it, maybe even based on the MOA of the drug, maybe of the starting level of fibrosis, as Laurent said. It's a difference if you change an NIT from a high level to a little lower level versus like the medium to lower levels to nothing, and the dynamics of the change. So the answer is not easy, and it's probably not going to be one imaging biomarker by itself. Maybe we'll see some compendium diagnostics, and I've more recently learned about about, for example, sex hormone binding globulin. This is something that's affected by resmetirom binding to targets. So you might have some indirect markers that reflect the MOA of the drug working in a particular patient to correlate that with then some indirect markers of fibrosis and inflammation, and in the end come up with a surrogate to suggest that this drug is working in this patient.
Yeah, I think that's an important point. So the FDA has always expressed an interest in tests of target engagement, which is basically what you're referring to, Jörn, that you want to know that at least the drug is getting to its molecular target. And that doesn't guarantee that having done so, that improvement will follow, but at least it shows you the drug gets where it's supposed to be.
Can I ask a question, Laurent? I'm going to presume the study didn't include CAP, and it was purely the stiffness that it was looking at. And I wonder whether or not we don't utilize CAP as much as we should, particularly now that we have it, because certainly in my practice and most of the time when we were looking at the patients, if the CAP came down, the inflammation came down. So we're able to determine to some extent the level of inflammation is dropping as the CAP score. And it's used in alcohol as part of detox as well. We look at the CAP to invigorate and look at that, and then the stiffness settles and the CAP, we keep coming down with detox and rehab over a number of time. Are we not combining both factors for something like FibroScan that can show us where there are changes in the liver that then affect liver results? I think Stephen Harrison on here regularly says to look at inclusion criteria for a NASH study, you really need a FibroScan of over 12.9 to account for the AST and the inflammation that's going on. So by watching CAP drop, there could be some more detail. And we do need the evidence to say that that is reduction in inflammation rather than just purely effect, because you can see fatty livers with normal enzymes, or you can see fatty livers with really high ALTs, ASTs, which I suspect is where we're seeing that fibrosis stage against people who say it's just benign fat and no fat in the liver is benign. So are we not utilizing what we now have as well as we should?
So to your point, my understanding is that CAP is more related to steatosis and inflammation. The truth is we don't have much data, again, paired liver biopsy. I think, the interesting study would be to compare MRI-PDFF, that is, of course, a much more sophisticated technology and more accurate than CAP. But the major advantage of CAP, in my opinion, if a drugs go to the market, not sure everyone will have access to MRI-PDFF, for instance. So you might need a technology that is maybe not as sophisticated, but that is able probably to capture the changes in steatosis, for instance. For the time being, I think I use it to motivate the patients, especially when they lose weight. So you're not really sure about the respective influence of course, if you're losing weight, you might also decrease steatosis. But I think the numbers talk to the patients. They like to see they come up, they have 350 or even 400. And then after 6 months or even a year, they come back, they have lost weight, and let's say they have 280. So of course, this is very simple medicine, but I consider this is significant. But I'm quite cautious on the variation of CAP because we don't have a well-designed study showing that is clearly correlated first to steatosis decrease and of course on the midterm to outcome. Another issue is there's a few studies actually, and it's a bit controversial. What is the influence of steatosis on liver stiffness and especially of CAP? There were some studies suggesting that if your CAP is high, there's a risk of overrating fibrosis, liver stiffness and fibrosis when there is a lot of steatosis. I have to say it's not completely clear what is the clear influence of steatosis.
Scott, can I then ask on that particular point whether if there's any stellate change difference between inflammation at different levels of steatosis within the liver?
Absolutely. Simply put, most of the activation of stellate cells will be driven by inflammation, not by fat. Having said that, you also have this concept, which I think is real, of lipotoxic mediators coming from fatty hepatocytes. Whether those lipotoxic mediators are directly driving fibrogenesis or are inciting inflammation to drive fibrogenesis is not clear, but certainly not all fat is the same. Unfortunately, the tools that we use clinically to measure fat are very crude and simply measure the volume or the amount of fat in the whole liver, whether it's MRPDFF or CAP. So we can't really tell which kind of fat the patient has, but I do think we're going to come to realize that just because you see fat in a CAP or an MRPDFF doesn't really tell you anything about the inflammatory milieu, or very little.
Yeah. And just to add, and I think we've said this before here, as the liver progresses to cirrhosis, we're losing fat. So some of those signals are seen with MRI PDFF, to a certain extent with CAP. And I share Laurent's cautioning, which is scientifically motivated in this experience, that CAP, we don't have as much data. For the individual patient here, I hear you, Louise, I've seen those patients, I put them on interval fasting or something, CAP goes down, they're very happy, they feel reinforced, and they're going to continue doing this. So it's more of an individual tool here than a general I use.
That's interesting, though, because there is a behavioral component to this, right? As we get drugs, we're going to need to keep patients on them and get patients on them and keep patients on them. And going back to Scott's initial question, if you try to impress on a patient the severity of a disease, but it's only going to work 25% of the time, and we're not going to be able to tell you whether it's working for a significant period of time, there's an inherent tension in that message. If I really should be worried about this, I want to know quickly what's happened. Behaviorally, that gets tough to manage, and I think it's tougher to manage when you get outside hepatology practice, where the doctor doing the prescribing isn't going to have the sophisticated ability to explain and put it in context.
Yeah, and obviously what makes the liver disease uniquely challenging is you can't track symptoms. If you're putting a patient on medication for rheumatoid arthritis or inflammatory bowel disease, all you need to do is ask them how they're feeling, and they'll tell you whether the drug is working. And in most cases, the placebo effect aside, in most cases, that will tell you whether the drug is effective. We have no such benefit in tracking patients with liver disease on meds.
Look, in my own life, I've seen that 10 years ago. If you're being treated for adjuvant cancer, right, and there's no ability to know whether it's going metastatic or not for some significant period of time, which there might not be. It's a very, very interesting way to live. Let's just put it that way. Now, there wasn't a major issue of compliance because the nature of therapy was once every 3 weeks show up. But if it involved daily medication, I could see patients, some patients at least, in the absence of data over time, needing greater encouragement to keep inducement to keep complying. We're not there yet because we don't have medications, but it's going to be an interesting issue as we go forward, I think.
And to pivot a little bit in the remaining few minutes, the 800-pound, or now it's shrinking to 600-pound gorilla, are these weight loss drugs. We don't really know how they impact liver disease, how consistently, which patients will have a benefit. We do know in the phase 2 trial of semaglutide that there was an improvement in NASH resolution, but they didn't move the needle on fibrosis. So that's going to become a huge variable because we're going to find that more and more patients with metabolic syndrome are on one or more of these drugs. Tirzepatide, semaglutide, they're going to permeate the entire clinical space, and we're going to need to account for that. My prediction, which is a total educated guess, is that there are some patients who will have a liver benefit from weight loss and defatting the liver, and others who don't. And it will be incumbent upon us to figure out which are which.
Yeah, so the other question that goes along with that, I think, Scott, and then we'll kind of jump, and I don't know if this was covered in the meeting or not, is when you go to the dual and triple agonist incretin agents, where the second mode of action is more directly tied to the liver than GLP-1 is. Does that change the calculus for the relationship between weight loss and effect on liver performance?
Well, we have no idea, and I'm not aware of any studies that confirm any direct benefit on fibrosis for GLP-1 or agonists or glucagon agonists or any of the other drugs. The hope and expectation is that if they benefit liver disease, it will be through its metabolic effects on liver and maybe adipose as well.
That's exactly right. If my camera was on, I was nodding. I saw Laurent nodding. We don't have that evidence yet. And as a matter of fact, they didn't show that, albeit 72 weeks of treatment and smaller. So we'll have to learn and see where it ends up.
Yeah, see, my further comment to Scott's point, in addition, the fact that drugs have different mechanism of action, some there is no weight loss, and some, like the one you mentioned before, the incretin, there is weight loss. But this is a major confounding factor when using non-invasive tests, especially, for instance, liver stiffness. And we don't really know how to appreciate the effects, whether it's related to the decrease in BMI or a true effect on fibrosis. And coming back to Jörn's point initially, I completely agree that it's very likely that we will not use a single NIT, but what I call unrelated NITs, going in the same direction. So let's say in a world without a gold standard, concordance is very important. And let me explain. If you're using, for instance, ELF test and liver stiffness, they are two unrelated because they have different approaches. And the drawback of each test does not interfere with the other test. For instance, BMI has no influence on ELF, whether it has an influence on liver stiffness using VCTE, for instance. And for instance, if you have patients with BMI above 40, you should not trust a liver stiffness measurement and start treatment, for instance. This is a major drawback of the use of VCTE. So if you have at least 2 or maybe 3, you could use ProC3 as well, or another one going in the same direction, I think this is a very strong signal that something is happening. But still, this is not yet in the clinic, because at the individual level, it will be very difficult. And then we'll also likely go to a la carte treatment, combining different drugs with different mechanism of action. So this adds another layer of complexity. So in a nutshell, I think NITs are very promising, because I think everyone is convinced here that we need to get away from liver biopsy. But to implement this in clinical practice, we're not there. Definitely.
So thanks, Laurent. Thanks, everybody. In the few minutes we've got left, we lose Scott in about 4 minutes. Everyone else maybe can stay a bit longer. But I'd like to ask each of you to comment on something you thought was important in the meeting that had nothing to do with NITs, since that's where this whole discussion has been so far, pretty much. Well, Scott, something in the session that you chaired that was not about NITs that you found particularly interesting or compelling or thought-provoking?
Yeah, I liked, there was a session about genetic variants that was capped off by an expert in diabetes and expanding the lessons learned about personalized medicines in diabetes to the care of liver disease. And conceptually, I found that very satisfying. They don't have all the answers yet, but there are genetic variants, and that was a session I chaired, that are increasingly understood as to how they put patients at risk for liver disease or not. We don't know how to use that information to decide who should be treated with what drug or treated at all. And the diabetes field is ahead of us, and so I thought the lessons learned there were valuable, even if they're early.
Okay, great. And thanks for joining us today and making time in your schedule on fairly short notice. It's great seeing you. Hope to see you soon.
Always a pleasure, and I will sign off and say farewell to my colleagues until next time.
Bye now. Thanks. So, Laurent, you next. Something in the meeting that had nothing to do with NITs that you found particularly compelling or thought-provoking.
In line with what Scott had just said regarding genetics, there was a session on pediatric NASH that I found very interesting, because, of course, this is a setting where genetic is likely much more important than in adults, because the children, of course, are not exposed to alcohol, for instance, to other factors for liver disease, even though when they get teenagers, some might have already diabetes or, of course, obesity. But this is probably a model that is more pure than the so-called adult model. And I found it interesting because I realized that there was so much to be done in this population. Because, of course, the pediatrician, they do not perform as many liver biopsy as we do in adult patients. And the data still remain limited, and there's a lot to be done. So I found it very interesting, and I learned a lot of things.
Thank you. Jörn?
Yeah, the genetics were interesting, but I'll move on now and say that in the same session I was speaking, there was a statistician. He started out with a theoretical question whether you want a pill that increases your IQ or your good looks. And I said I was left behind baffled, trying to debate both ways. Taking them both maybe would have been my answer. I don't know. Anyway, he introduced a concept that was called desirability of outcome ranking, DOR. This is a statistical assessment of an outcome and gives partial credit to both, let's say, the efficacy endpoint, the primary outcome, but also taking safety and harms into a reduction. Let's say we cure, this is a hypothetical drug because nothing like that ever happened, but if we regress cirrhosis down from F4 to F0, but then the patient dies half a year later because of some weird cancer, obviously you met the endpoint, but you haven't taken the undesirable outcome into account. And then on the other way, in the end, he said, there are ways to balance statistically the safety profile of a drug and the efficacy. And I felt reminded of the Intercept story or the OCA story, because here we struggled with some safety aspects, albeit meeting the endpoint. And I was wondering how a DOR analysis of that data set would have looked like. It reminded me that there is more than the primary endpoint for efficacy we might be exploring, and we have to take safety into account. And many of the drugs we're seeing far advanced now are very safe and have good additional benefits that might even harden the reason to use them. And therefore, I felt very stimulated by that type of statistical analysis, which the FDA has, according to his presentation, has gained more interest in.
Jörn, was this fellow from George Washington University? Maybe I'm forgetting his name.
Yes.
Or American University, one of the schools in D.C.
Scott Evans.
Yes. Thank you. I wanted to say he presented on this maybe at Liver Forum last year or somewhere. And I, as statistician, was exceptionally attracted to what he was talking about for exactly the same reason. I think it's an innovative way of looking at this and really important and helpful, I think. So thanks for bringing that note to the conversation. Okay, partners in podcast. In the few remaining moments we've got, what else about this meeting would we like to discuss, or should I just move to a simple closing question?
Well, I would say that the hospitality of France and Paris is exceptional. It was a great meeting. It was great to be there, in particular standing next to Laurent, close to the Eiffel Tower, where this is his city, and he has some nice stories about the city. This was personally very rewarding. Thank you for that, Laurent. But that was on the personal note. So I think that Paris NASH, again, being a think tank and being able to meet those people that drive the field is something very exceptional. And also the ability to, Europe, US and Asia come together there. I think that's unique. So again, very stimulating this year. And I think there is a round birthday next year. It'll be the 10th edition. I'm going to be looking forward to that.
Laurent, anything to add?
No, thank you, Jörn. I noticed that people seem always happy to come to Paris. So, of course, been living for many years in the city. I'm very happy to welcome you and hope we can welcome you as well next year for other meeting.
Well, I would desperately like to be there next year. I really wanted to be there this year. And this is the second year in a row that life intervened in my plans to get to Paris for Paris NASH, but hopefully the third time will be the charm. Louise, anything you want to ask or comment on before we go to final questions?
I just wondered, I think Laurent might have been at the last session with William Alawazi on the Global Health Corner, and there was some interesting stuff there. Was there anything that came out in pathways, future developments, how we're going to do, rather than what we're focusing on now from that session?
Okay, so maybe I will comment very shortly. Actually, there was a patient that told us his story, and to make a long story short again, he was diagnosed with cirrhosis after having a FibroScan and NASH cirrhosis, of course, and he was trying to explain that no one had told him before. And after a long discussion, finally, he said, why don't you screen people like me with risk factor for this kind of thing not to happen? And this was exactly what we were trying to do. Is, we as experts have been working for years trying to convince outside of our field that now we have effective tools, of course, to spot among general population people at risk, but also the tool to be able to spot those with cirrhosis and, of course, bring them to or refer them to expert center and try to treat them once the treatment comes to the market. So that was exactly what we are trying to do, and we were very happy that this patient with this story was illustrating what we've been trying to do for the last 10 years.
So it's interesting you say that, because when I think of the NASH-specific patient advocates in the U.S. and patient advocacy groups, the two that come to mind were both started by folks who learned that they had cirrhosis in an emergency department in a hospital after 50 years of care. In one case, in the presence of HCC and requiring a transplant, the other case not. But I think patients who've been diagnosed are clearly the most compelling and powerful source on this issue, because they know all the times that they weren't told things that could have helped them. Pardon the double negative. So that's fascinating.
I think what they're also very good at, Roger, is detailing all of the missed opportunities that we have had in healthcare to miss those markers. And one of the biggest ones that we all hear about is, my doctor told me my liver tests were normal and therefore my liver was fine. So there are multiple missed opportunities. We just have to miss less of those opportunities, and that's still the case that we hear too many times.
I think the point you're making is very important. This illustrates the fact that we need to educate our colleagues and also try again to raise the awareness of patients, because it's difficult with asymptomatic disease. And as you stressed, Roger, most of cirrhotic patients so far are diagnosed at a late stage. So fortunately, this patient had compensated cirrhosis. But let's say in 2/3 of cases or even more, they come to the ER department with a complication or HCC or a candidate for liver transplantation, and this is a bit too late. And still, I think a very simple message to convey to the GP community is the fact you need a shift in paradigm. So far, GPs have been educated to refer patients to an hepatologist if they have abnormal liver tests. We know that abnormal liver tests are poorly correlated with outcomes, and especially with fibrosis. So I think we need to shift the paradigm to, you need to diagnose fibrosis, whatever the liver test, and based on risk factors. The patients more than 40 with all the metabolic risk factor should undergo FIB-4 and be tested for fibrosis and referred to an hepatologist, even though he has no symptom, normal liver test, if the FIB-4 is elevated, to have a second look. So this is simple in principle, but you need to come up to the GPs with very simple message. And remember, they're overwhelmed by their patients, by the cardiologist, by the diabetologist, by the obesitologist, and we need to find a voice for the liver in that environment. I think this is critical.
Laurent, it's interesting you say that. Mazen was with us a couple of weeks ago talking about MASSA. His comment was that ultimately the goal is to find our way to something that looks like an A1C test, where it's got a single number on it, a primary care doctor can trust it. On the way there, I think there are just going to be bumps. And I couldn't agree with what you say more. Right now, that's the best we can do. Ultimately, though, it's going to take, I think, drugs and maybe some better tests before the message breaks through as clearly as we would like. We have to keep trying every day. It just might not succeed as completely as we would hope, I think. Wrap-up comment. Anything you would expect to see at Paris NASH 10, besides the celebration of the round number, that the people should look forward to?
I'd be hoping to give a more robust talk on how to measure treatment response, also based on some therapy emergent data that we'll see in parallel to the phase 3. That's really my hope. And any sponsor listening, please share that data with PIs like Laurent or myself to be able to give them meaning to these individual NIT changes. I think it will be important.
Fantastic, Laurent.
I would echo Jörn. I think this is a very important year. This is kind of a transition year. And within the forthcoming year, we're going to get a lot of more data, not only on treatment, but also NIT and the treatment. So this is critical. Yes.
Louise?
Yeah, I'm going to share the same. I'm certainly going to share Jörn's. Let's get more of the data from the trials once they can release it to let us know what we can do in the clinical environment. What are we monitoring to be able to make those decisions for patients?
I'm not even going to add a comment because it would be a complete repeat on what the three of you have said. I think you captured the most interesting parts of the landscape quite brilliantly between you. So with that, let's thank Jörn and Laurent for giving us a significant part of their evenings, and Louise for getting up at 1:30 in the morning to do this. I'll be back with a business report in a couple of minutes, and we will see you again next week with more interesting content. Thanks, folks.
Thank you.
Thank you.
And now for the Season 4 Episode 4 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. The specific stories we're reading this week, those about the success of the counteroffensive or how successful it's been, others about overall Russian strength, are confusing. But clearly, the Ukrainians make progress as Putin keeps reaching out more and more to the global rogues gallery for support. Today, the North Korean dictator Kim Jong-il, he of the love affair with Donald Trump, and his highly protected stream of trained cars is heading towards Vladivostok to be treated as a major global ally. Meanwhile, the U.S. and Germany and other European countries are making increasingly powerful weapons available to Ukraine. Maybe later than requested, but perhaps soon enough to make a real difference. Time will tell. We all need to stay resolute. Slava Ukraini.
September is a big news month.
I'm not going to say any more about why last week's episode did not happen. You've already heard my comments at the beginning of the recording itself. That said, the rest of this month is big for news. Today, we reviewed some highlights of Paris NASH. Next week, we will discuss the two-day FDA advisory meeting on NITs. That meeting ends Tuesday at 4:45 East Coast time, so there's a chance we will not get the recording out until Thursday, but I hope not. The week after that, we covered the SLD Summit in Prague, and then it's on to October.
September downloads reflect that we did not produce an episode last week.
We had 1,800 downloads the first 10 days of this month. Not surprising given that we did not record last week. 18 months ago, that would have felt like a great number, but now obviously we're ahead of that. I anticipate listener numbers will rebound quickly throughout the rest of the month.
This week's Vault episode looks back to Paris NASH 2021 for our most downloaded conversation ever.
This week's Vault episode goes back to September 2021 and part of our review of Paris NASH 7. This was by far the most listened to podcast in our history, with more than 3 times as many downloads as any other episode or conversation. In it, Stephen Harrison discusses a basic science session from Paris NASH that included 3 talks, one of which was from our friend Scott Friedman. Jörn Schattenberg amplifies on Stephen's comments and I ask questions. Despite being 2 years old, it still has fresh and important things to say. And that's it for this week. I want to thank Scott, Laurent, Jörn, and Louise for joining us at their disparate time zones on fairly short notice. And also thanks to Mike and Jake for getting this episode out. Next week, as I mentioned, we record an episode to cover the FDA's NIT workshop. Since it doesn't end until after Tuesday, we might not get it turned around until Thursday morning. We're shooting for the end of Wednesday. Sorry for being redundant about that, but I want to make sure everybody understands. Until then, stay safe, surf on. We'll see you next week on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.